So let's go ahead and kick things off. So again, welcome everyone to the Society of Thoracic Surgeons General Thoracic Surgery Database monthly webinar. Today is Wednesday, November the 13th, 2024. So thanks everyone for joining today. Let's see here. On the call with me today from the STS side, we have myself and Carol Crone, Banu Yatsi, Emily Conrad, Katie Lothrop from our core group. Melanie Bent is on the call today, joining us as well. Nancy Honeycutt and Ruth Raleigh. So thanks everyone for being on the call today. We appreciate you joining. For our agenda today, kick things off, I'm going to provide our STS updates. I'm going to revisit the fall 24 reporting updates. I had initially covered these back in, I think it was the August webinar, I believe. And I'm also going to touch on the revised risk models. This will be a very high level overview as Leanne is very far away from being a statistician and will not be able to go in a lot of in-depth details on the statistical side of things, but I will give you an update on a very high level update review of the revised risk models that'll be rolling out with the fall 24 report. After the STS updates, I'll turn things over to Ruth for a few educational updates. And then as usual, we'll end things with our Q&A. So if you do have questions, please be sure to put those into the Q&A. I think we'll have the chat turned off by then, but it's probably already turned off, but submit your questions via the Q&A. If you prefer to just ask your question, just raise your hand, we'll unmute you. Just be sure that the microphone is enabled on your end. All righty. Before we hop into the STS fall 24 updates, reporting updates, just a little bit of post AQO info. Just a reminder, the deadline to complete your online evaluation and claim continuing education credit for AQO 2024 is Friday, December 13th of this year. So again, the deadline for claiming education credit is Friday, December 13th. Recordings of the lectures and discussions are available in the virtual platform, and you can view them in the AQO virtual platform up until this coming Friday, November the 15th. After this Friday, all of that recorded content will be moved over to the STS Learning Center until AQO 2025. So again, that content will be removed from the virtual platform that you currently have access to, and it will be moved over to the STS Learning Center, and you can still access all of the AQO 2024 content up until AQO 2025. It'll just be moved over into another location. All right. And if you have any questions about that, just put your question in there, or you can just reach out to Emily Conrad, and Emily can help you with any of your AQO access information or questions regarding CEUs. All right, for our STS updates, the November training manual, that will be posted by the end of this week. So stay tuned for the November training manual. For our fall 24 harvest update, just a reminder, this report does include surgery dates of July 1, 2021 through June 30th of 2024. This will be our first report containing only version 5.21 data. And this report is scheduled to be released next week on Monday, November the 18th. So as soon as the reports are available, STS will send a formal notification out to our GTSD participants. This notification will include your surgeon representative as well. So the announcement will be going to all of our primary data and file contacts, backup contacts, and surgeons. So that notification will be sent out to everyone. The 2025 harvest schedule is posted out on the STS website. Our spring 25 harvest close date is scheduled for March the 7th. And then our fall 25 harvest close date is scheduled for September the 5th. Public reporting update. Our next public reporting update is scheduled for January 2025. And just a reminder that the public reporting refresh will include the primary lung cancer for resection composite only. This will be replacing the lobectomy composite. So if you have any questions about public reporting, please reach out to us at we have a specific email regarding public reporting. Emily or Carol, if you could put that into the chat, I should have included that here. But if you could put the email to contact Sydney regarding public reporting. Sydney will be able to answer all of your public reporting questions. Just email her directly at that email address, and Sydney can answer any of your public reporting questions.
What am I putting in the chat box?
The email for public reporting questions.
I just know Sydney's email.
Yeah, I think it's publicreporting@sts.org.
Thank you.
I think
Oh,
that's,
Lord.
but you may want to check. I'm pretty sure that's what it is. All right, fall 24 reporting updates. Again, I'm just going to touch on this as I said, we had discussed this in our August webinar, but again, I did want to review all of this information again, as we do have some new data managers, and also just to give a refresher, since the reports are scheduled to be released on Monday of next week. So again, the fall 24 reporting updates include the implementation of our revised risk models, the resection for primary lung cancer and esophagectomy. The lobectomy for lung cancer risk model results will no longer be reported out, so you will no longer get a star rating and composite rating details for the lobectomy composite. However, with that being said, the lobectomy legacy and benchmark reports will still be available. So you will still be able to have benchmark data for your lobectomies. However, you will no longer receive a star rating for the lobectomy composite. The STS and NIS comparison outcomes reporting will now utilize the resection population. Previously, it did utilize strictly the lobectomy population, but again, that we are changing that over to the STS and NIS comparison will now utilize that resection population. Also, with the fall 24 report, we have in the analysis side, we have removed the required fields criteria for our newer data managers. If you are, which we actually just got a question about this today. So our newer data managers, if you see on the current data collection form, you'll see some of the variables fields are in blue and underlined, and it states that it is a required field. We have removed that required fields criteria in analysis. Previously, if one of the records was missing one or more of those required fields, that record was excluded from the analysis. However, beginning with this fall 24 report, that is no longer the case. Please keep in mind that even though we have removed this required fields criteria, this does not mean you should no longer collect these data. Please continue to collect these data. For example, and I'm going to use ECOG, which I used in their previous webinar. Analytics continues to see a slight increase in the overall percent missing for ECOG. Just a reminder, to ensure that your patients are risk adjusted appropriately, just know that if this data is missing, if you're not collecting it, some of these variables are used in the risk model, and if that data is missing, this data is imputed to the lowest possible risk, and therefore certain patients may not be risk adjusted appropriately. This data will be imputed to the lowest possible risk. So you want to make sure that your patients are risk adjusted appropriately. So again, even though this required fields criteria is removed from the analysis, this does not mean you should not collect these data. If you have any questions about that, please just put it in the Q&A. We're happy to answer. The GTSD analysis overview will be updated or has been updated to reflect the fall 24 reporting changes. This updated analysis overview will be available with the release of the reports on Monday. The updated analysis overview will be posted in the IQVIA library and will be available for download as soon as you access that report. So that analysis overview will be available. As soon as you download or access your report, I encourage you to download that updated overview. That updated overview will have all the information you need to understand your report, to certify your numbers. It'll have all the inclusion, exclusion criteria for each of the sections. All that information will be updated for this fall 24 report. I did, so in the next few slides, I'm going to briefly touch on the revised risk models. Again, like I said, I'm not going to go into a lot of detail because I am so far away from a statistician. It's just not even, I can't even begin to explain it. So I have talked to Dr. Cedar. Dr. Cedar gave a phenomenal presentation at AQO on the revised risk models. I did get his permission to share some of these slides with you all today. So I know not everyone was able to attend AQO, but I thought it was important to also share these slides. He did a great job with a few of these with this presentation. So I wanted to bring some of these slides here and present them as well. So a lot of the several questions that we've gotten is, why why did we develop newer revised risk models for GTSD? So per Dr. Cedar in his presentation at AQO, since 2016, model updates, the number of cases has, almost doubled, or what happened there? Has doubled, and to where we have right now, I think over 800,000 procedures. So the surgeons decided to do a revision of the risk models, one, to utilize more current data, to make the models more inclusive, to consider new potential risk factors, also to harmonize methodology with the adult cardiac surgery database, and also to include those preoperative variables only. Actually, let me go back here. I just wanted to borrow a little bit of the language from Dr. Cedar's presentation. So here, let me review a little bit of what he talked about at AQO. So with the revision, the GTSD task force aimed to develop the new pulmonary resection and esophagectomy models using the more current data with more cases from more centers to reflect a more modern practice patterns. They widened the inclusion criteria to include high-risk patients for a more real-world representative cohort. And they examined new potential risk factors based on recent evidence and availability of data. So they aim to create high-performing models using preoperative variables only to help facilitate the development of future general thoracic risk calculators. And I wanted to include this slide here, and this is just a snapshot from the analysis overview, just to let you know, with the revised models, there were no changes in terms of the inclusion criteria for category of disease and the procedures that were included. So just know from the previous resection composite or previous resection model to the revised model, nothing changed in terms of the category of disease and the procedures that were included. And again, this is just a snapshot from the updated overview that'll be released next week. So again, it'll be available in the overview. This is one of the slides that Dr. Cedar had presented that I thought was very helpful. He broke this slide down to identify the new variables that were included in the model, the reparameterized variables that were included in the model, and then those variables that were removed from the model with revision. So you can see the interstitial lung disease is new, DLCO, BSA, clinical cancer stage, payer status, Asian race, surgery date, and elective surgical status. These 6 variables were reparameterized. I cannot say that word for the life of me. And then 3 variables were removed: diabetes, pathological stage, and open versus MIS. Again, just a snapshot from the updated overview. This information, will be available, but I just wanted to include it here so you could see it of how it'll be listed in the upcoming overview. We have the short name and then the parameter for each of the short names for the revised risk models. Same for esophagectomy for primary esophageal cancer. With the revision, nothing has changed from the prior model in terms of category of disease and primary procedure. Again, same category of diseases, same procedures, no changes here. And again, from Dr. Cedar's presentation, a breakdown of the new variables, the reparameterized variables, and then the 1 variable that was removed. The new variables for the esophagectomy, I do not know why my computer is going crazy. I have no idea what's happening. The new variables for the esophagectomy revision include BSA, clinical cancer stage, payer data, CVD, surgery date, elective surgical status. reparameterized age, BMI, CBD, renal function, induction therapy, and resection type, and then Black race was removed. Just a little bit of information. So there were a total of 62 variables included in the final models. Some models were new, reparameterized, and removed. And again, just as I showed for the resection composite, here is a list from the upcoming overview for the esophagectomy, the short name, and again, the parameters that are included in the models. And this has been updated slightly since the August presentation. So again, if you compare the two, you might see a little bit of difference, but this is the list that will be included in the updated overview that'll be released next week. Also, for the revised model manuscripts, if you or your surgeons would like to review the manuscripts for the revised models, here are links to the papers that are located in Annals. If you have any questions, just reach out, but here are the links to the risk model manuscripts if you would like to go into a deeper delve into everything involved in the risk model revision. That's all that I have for the STS update side of things. I'll turn things over to Ruth for our STS education.
Hey everyone, so we're going to talk about a couple of educational concepts. The first concept that we're going to talk through a little bit is values outside of an acceptable range. So this text and this image are taken directly from the training manual, so you can read through this in context in the training manual as well if you would like. But essentially what it indicates is that when you're entering a value into the data collection form, some sequences have this concept of an acceptable range, which is the area between the arrows in this picture. And then they also have a concept of a usual range, which is this green area on this graph. Note that all of the usual range falls within the acceptable range. So if you have a range that is within the usual value, it is automatically within the acceptable range, but you could be outside of the usuals and still be acceptable. So if a value is outside of the acceptable range, typically what is done is that you use the closest acceptable value. So in this example, this is patient age. Let's say that you have a patient who is 118 years old and they're having a therapeutic lung resection for lung cancer. You can't enter the value of 118 because that's outside of the acceptable range for the age sequence. So what you would do is enter the value of 110 because that's the closest acceptable value. You want to go to the next slide, Leanne? So then you have to think about the concept of the usual range. So if a value is outside of the usual range, but it's within the acceptable range, you might get an unusual value warning when you enter that number. It's triggered. The reason that warning is triggered is because we're trying to have sort of guide you to double check that you haven't made a typo. So for example, you entered an age of 2 instead of 20, or that units are correct. So we know that in the largest tumor size sequence, it's important to enter the value using the correct units, millimeters versus centimeters, for example. If an unusual value that you've entered is correct, it should be submitted. You can ignore that warning that's triggered after you double check. Yep, I use the appropriate units of measure. This is a correct entry. I don't have a typo. Just go ahead and submit the unusual value, recognizing that it's within the acceptable range. We're going to walk through a couple of examples, which I think make it a little bit more clear. You want to go to the next slide? So first of all, shout out to Erin and her excellent presentation at AQO on the Barbie Ken data manager surgeon conversation. I now conceptualize all data managers as Barbies and Kens. So thank you, Erin. So all of these, what would you do questions? I have Barbie pictures. So the first polling question, your surgeon performs a lobectomy and resects 26 lymph nodes. You code 26 for sequence 2030. Upon submission, you receive a warning for sequence 2030 that you've entered more than the usual number of lymph nodes. The usual high is 10. What do you do? Code 10, double check your pathology report in code 26, or leave sequence 2030 blank. I'm not sure if I'm going to be able to see the answers coming through, Leanne, so just let me know.
Sorry about that. Yep.
I
Oh,
might be able to if I hit.
yeah, I think it's, if someone makes you a co-host, if you're not a co-host, hold on.
That's all right. You can just move them along.
Yeah,
I don't mind.
okay. All right, yeah, I'm gonna go ahead and end
That's
it.
you. Oh, Leanne, you would need to
Oh,
make her a
sorry.
co-host.
Oh, sorry.
No problem. So the majority of the group got this one correct. You're going to double check your pathology report and you're going to code 26. Because as you can see, the acceptable range for sequence 2030 is a low of 1 and a high of 60. So even though you're outside of the usual range of 1 to 10 for this sequence, you're within the acceptable values. So you're going to code 26. Next slide.
Yes, ma'am. Okay. Oop. All right.
Your surgeon performs a lobectomy and resects 65 lymph nodes. You code 65 for sequence 2030. Upon submission, you receive an illegal value warning for sequence 2030. What do you do? A, code 10. B, double check your pathology report and code 60. C, keep trying to code 65. D, leave sequence 2030 blank.
Do, do, do. All right, we got a little bit of everything. Well, all right, I'm gonna go ahead and stop and share results.
Okay, so both of the group also got this one correct. You're going to double check your pathology report in code 60. The highest value that the system is going to allow you to enter for this sequence is a value of 60. And so you'll go with the closest you can get. If I want to go to the next slide. Okay, so a little bit of bad news. Sequence 4290, I think, is probably the most hated sequence in this version of the training manual. The plan is to retain the sequence in the ongoing version upgrade for the GTSD registry. The reason for that is because it links back to a government related quality metric, which is really important that we stay aligned with sort of the national guidelines. And so we're going to probably keep this measure is the thought. We have struggled historically to abstract this sequence. I think just because it's a little bit confusing the way that the government chose to word something, surprise, surprise. But I think the good news, if you want to go to the next slide, Leanne, and that means that we can really dig into honing our skills for this sequence now, and our time spent on sort of nailing down how we abstract sequence 4290 is not going to be wasted. It's not going to go away in the next version. So let's dig in and learn a little bit. I put together this matrix for how to code sequence 4290, which is substance abuse screening and counseling. So what you want to do is sort of walk yourself through this matrix and then code accordingly. So the first question you're going to ask yourself is, was my patient physically and mentally appropriate for substance use screening and counseling? If no, they can't physically or mentally be screened or counseled, you're going to stop and you're going to code NA to 4290. If yes, you're going to continue. The next question you want to ask is if your patient was screened for illicit drug use, alcohol abuse, and tobacco use. If they were not screened for all three, you're going to stop and code no to 4290. If they were screened for all three, you're going to continue. The next question you're going to want to ask yourself is if they screened positive for any of those three: illicit drug use, alcohol abuse, and or tobacco use. Doesn't have to be all three that they screen positive for. If they screen positive for 1, 2, or 3. If no, i.e. the patient screens negative times 3, you're going to stop and you're going to code yes to 4290, meaning your patient was screened and it would not have been appropriate to counsel them because they didn't screen positive. So there's really no more work to be done. So you just stop and code yes to 4290. If yes, i.e. your patient screened positive for one or more, you're going to continue. In the last step of the process, you're going to ask, was my patient counseled for all substances for which they screened positive? If no, you're going to stop and code no to 4290. If yes, you're going to stop and code yes to 4290 because the patient was both screened and counseled for all relevant pieces of this sequence. If you go to the next slide, we have some examples on this one. Okay, so Mary Smith is a 43-year-old patient of Dr. Jones who recently had a lobectomy for stage 1A lung adenocarcinoma. She completes screening for substance abuse as follows. She's a lifelong non-smoker. She drinks an occasional glass of wine with dinner and has no history of non-medical prescription drug use or illicit drug use. Your facility algorithm does not define an occasional glass of wine with dinner as unhealthy alcohol use. No counseling is provided. How will you code sequence 4290?
Not related note. I now have the "I Want a Hippopotamus for Christmas" song stuck in my head.
I always have it stuck in my head. It's permanent after like Halloween goes by.
All right, let's see here. We've got, all right. Looks like our numbers have slowed down, so we have good response. So, all right, share results. We're a little all over the place here, Ruth. How do we do this one?
Yeah, so I think if you go to the next slide, I sort of walk through my logic on how we arrive at yes as the correct answer. So first question, was Mary Smith physically and mentally appropriate for substance use screening? Yes, she was screened because her surgeon or surgical team completed that screening. So you know that she was mentally and physically capable of being screened as they completed the screening. If you want to go to the next slide again, sorry.
Yep, nope.
Was my patient screened for illicit drug use, alcohol abuse, and tobacco use? Yes, she was. So she is a lifelong non-smoker. She drinks the wine with dinner, but her facility, like per the facility's guidelines, that does not screen her as being positive for alcohol use. And she did not screen positive for illicit drug use. So we're going to continue to the next step. Did she screen positive for any of those three? No, she was not positive for any of the three. So you're going to stop and code yes to 4290, meaning she was appropriately screened and counseled if applicable for anything that she screened positive for. I think it's a little bit tricky because the question is not, did your patient receive, was your patient screened and counseled for all three? They only have to be counseled if they screen positive. Next slide is another example. Tim Jones is a 65-year-old patient of Dr. Crone who recently had an esophagectomy for esophageal cancer. Well done, Carol. He completes screening for substance abuse as follows. Current smoker with a 40-pack-year history. He drinks 4 to 5 shots of alcohol daily. No mention is made of screening for drug use. Counseling is offered for tobacco and alcohol abuse. How would you code sequence 4290?
It's still got, responses are still coming in.
Dr. Crone sounds like a great name for a doctor.
Next webinar, I'm going to use, what's the dog's last name? Bammers?
Bammers. Talladega, Alabama, aka Bammers.
Dr. Talladega.
Dr. Talladega, Alabama?
Yes.
All right.
Goodness.
We got some yeses and some nos, Ruth. What's the answer?
So if you want to go to the next slide, I'll walk through the logic on this one.
Yes, ma'am. That would be helpful, huh?
No problem. So was the patient mentally appropriate for substance use screening? Yes, they were screened, so they were capable of being screened. Continue. Was my patient screened for illicit drug use, alcohol abuse, and tobacco use? No. So they mentioned that they were screened for alcohol. They mentioned they were screened for tobacco, but they neglected to assess this patient for illicit drug use. And so you stop at this point and you code no to 4290 because they're missing a leg of their imaginary three-legged stool for this sequence. So you can't complete, you just stop and you say no, because whether they counseled or not is irrelevant at this point because they missed a piece of the screening assessment. So a final word on this sequence. In sort of preliminary audit data, I think what the auditors are seeing is a high volume of NA responses. NA should be selected in very, very rare circumstances for the patient population that's being audited. If you think about a patient having elective lung resection or an elective esophageal resection for cancer, most of those patients are coming through the outpatient setting and are part of shared decision-making conversations that are occurring in the office. They're not trauma patients coming in through the ED that are sedated and unable to be screened or counseled. And so really most of these patients are likely to have been physically and mentally capable of being screened. I think there are some cases where patients have significant cognitive delay, and in those instances, it might be appropriate to code NA for our patient population that's being audited. But that's really the only example that I can think of where NA would ever be an appropriate choice for sequence 4290. But if anyone has any other times where they feel like they've appropriately selected NA, feel free to put it in the Q&A and we can talk through those cases as well.
Perfect. Thank you. Next, so we have questions, and of course, just a reminder, if you have questions, just put those into the Q&A. If you'd rather just raise your hand, just raise your hand. We'll unmute you. Just make sure your microphone's enabled on your end. Okie dokie. Questions. Our first one was from Tracy, and this was a follow-up, Ruth, I think, to her first question regarding the neoadjuvant data. For any updates on the data received, her leadership is asking for updates as we have been submitting data but have not seen anything recently regarding the data that is being received. I do know from our most recent, we actually have our monthly task force calls, and I provide an update to our task force each month on the data that is coming in through the module. So again, thank you to everyone who is submitting data and continuing to submit data. Dr. Broderick and others are starting to look at the data that is coming in. I believe we have over, I think the last update for last month, we had over 500 cases that have been submitted through the module, which is absolutely phenomenal. So again, thank you to everyone that's submitting. So they are starting to look at that data. I do know also looking at that data, they're also we are in the process of a GTSD upgrade. So I think they are using that data as well to determine, if we add any additional variables to the current data collection. So that data is currently being looked at. Hopefully we'll have more information to share with everyone as Dr. Broderick and team delve through the data, learn more, see what's there. But I will try and give you guys an additional update on our next monthly webinar after our next task force call to get more details on the plans and what they were wanting to do with that data as they're continuing to look at it. I don't know if that answered your question, but yeah, thank you. You're welcome, Tracy. All right, next question. Let's see here.
Before we jump into that, can I
Yeah.
say something about that topic?
Yeah.
I think
Sure.
one of the things that I found really fascinating and being part of the task force conversations is how interested the task force is on this REDCap data that's coming in, because it's so currently relevant. And as additional targeted therapies are considered for neoadjuvant treatments, I I think that there's just so much interest. This is such a timely data that we're collecting and so important to patients and how they're able to receive their care. I think there's a lot of interest in how we can reduce barriers to collecting this data for sites. So if you have any feedback on what's really a barrier for your site to collect this data, please feel free to email it to me, or Leanne, can I volunteer you for emails as well?
Yeah,
I think we'd love to have more sites there's a lot of sites that are participating, but we would love to have even more, just because it's such an important patient care issue right now in thoracic surgery, or lung cancer care, I guess I should say.
Yeah, and I'm sorry about that. I'm trying to pull up the numbers because I had a breakdown of the total number of sites that had submitted data thus far. I can't remember off the top of my head, but I'll look through and see if I can get that total number. I'm thinking it was around, I don't know why the number 88 is sticking out in my head of sites that have submitted data. I'm thinking it's 88, but I'll confirm that for you. So Nancy, can you send a link to the PowerPoint so we can send to our surgeons? So this PowerPoint slide, as with the others, though, it'll be posted out on the STS website. So you can download the slide deck and share with your surgeons. Also, if you're speaking specifically regarding the links to the manuscripts, the links to those manuscripts will also be included in the email announcement that comes out next week on Monday regarding the posting and release of the reports. So that your surgeons will be included on that email notification. So the links will be available, one in that email notification that comes out on Monday, as well as in this slide that'll be posted on the STS website. Did STS invoices come out? Carol, I think Carol or Emily.
No, they sure haven't.
Okay.
I think Derek, when I last reached out to Derek, he was expecting them in the next few weeks, and that was last week. So
okay, so I would think
next few weeks.
next couple of weeks, yeah. And then Nancy, if you have any other questions about invoices, or if you could email stsdb@sts.org, and they can Derek and Jane and team can help you there regarding invoices. All right, Laura, do we include every return to the OR with an incision being made in sequence 3670 post-op procedure complication? I get confused with the related to index procedure comment. For example, would an unplanned hip replacement fall into this field?
Hey, Laura. So this is really tricky.
We've had so many conversations regarding the, especially
we talk about this all the time. Yeah, it's tough because in the end, it's very hard to prove that trauma-related surgery. So my recollection of the details of your question were that the patient's hip replacement was related to a trauma. If you have a patient in that 30-day postoperative window and they're falling and then having subsequent orthopedic surgery, those surgeries are considered related to the index operation, because there's not really a way to prove that, to separate like falls in the immediate postoperative period from the index procedure. I don't know if that makes sense, the way that I'm saying that, but
she said it was a bike fall.
Right. 6 of one, half dozen of another, right? Like when quite often when patients are falling in that post-operative period, it's because they're on narcotics or their hemoglobin is a little low or whatever. And so we've talked about this in the core group many times. And in the end, the decision is always that those unexpected traumatic surgeries are required to be captured in as an unexpected return to the OR related to the index procedure.
Next question from Beth, September 22. It states we are to code yes to 4290 if the patient is screened and is determined not to use tobacco, alcohol, or non-medical Medicaid. What is that prescription? I'm sorry, I'm not
prescriptions.
Yeah.
Am I understanding you're not a code? No, you're correct. So that training manual advice is correct. I don't know if you want to go back to that slide, Leanne, where I've got the matrix.
Yeah, hold on. Oh, wait, sorry. There
Right
you go.
there.
Hold on. I was singing for you, Leanne, the Hold
you were
On
singing?
song. Yeah, that's the song I sing for the dogs when they got to go outside. I'm not ready to run down the stairs. Hold on. I sing a lot in the house.
So for question, so your patient
Chocolate.
was your patient was screened. Were they screened for all three? Yes. If yes, and the patient screens negative for all three, you're going to stop and code yes to 4290. So that aligns with the September 2022 update. I was just trying to restate it in a different way because um, I feel like there must still be confusion out there because we're not hitting this from a coding perspective when we look at it in the audit. And so I tried to make it a little bit more granular than that update. And then this matrix will be in the November training manual update. So hopefully that helps. It aligns with what's previously stated, just in a different way. Thanks, Leanne,
Oh, you're welcome.
for going back to my slide.
No problem. Nancy, where can we send our suggestions for the next upgrade versions? Send them to me, please. ljones@sts.org. Or you can send them to Ruth R. Raleigh@sts.org. Either one of us.
Please be advised that if there's something in the training manual that has a bajillion updates, trying to think of a good example. History of cancer. Like I feel like that's like a good example. We recognize that sequences with a lot of updates probably need some clarification in the next version of the training manual or in the version upgrade as a data collection point. And so everything that's in the training manual currently is certainly accounted for in the next version. And then also, if I've responded to one of your questions in the FAQ inbox with this is a great suggestion for the next version of the training manual, I actually put all of those in a folder. And then as we work through this process, I brought those thoughts that we've been collecting for the past several years forward. So by all means, please feel free to send them again, but I did keep track of those as well.
Yeah, and when the upgrades, we literally walk through every single variable with the surgeons, the task force. And then we have all of your comments and suggestions for each of the variables that we, present to them. So just know that, we do share that information and walk through it. Every variable with the task force. Okay. So Kelly, can you share our hospital number reflected in the QI webinar? What time frame was used for that graph? So in that for those of you that attended the QR webinar, the graph that Kelly's referring to, that graph was based on the spring 24 harvest period. So that would be January 1. I have so many dates in my head. So spring 24 harvest for GTSD was January 1, 2021 through December 31, 2023. And
I have a couple of people waiting for their site IDs. I apologize that I haven't gotten that to you yet, but I promise I will do those this evening.
Yeah.
So if you have not emailed me, Kelly, will you please email me at rraleigh@sts.org? And if you've already emailed me, then you'll get a response this evening.
Yeah. Perfect. All right. You're welcome, Kelly. All right. I think I don't see any other questions just yet. While we're waiting, if anyone else has any additional questions, upcoming GTSD webinars, our next monthly webinar is scheduled for December 11 at 2:30 Eastern. And then in 2025, our first monthly webinar is January 8th at 2:30 Eastern, 1:30 Central. Right now, I didn't put our next QI webinar. I'm working on that with getting that scheduled with one of our speakers, Dr. Lisa Brown, that we've invited, as well as, working with Carol and Emily and team here. Right now, I'm looking at tentatively scheduling that QI webinar for December the 19th at 2 o'clock Eastern, 1 o'clock Central. I'll update this slide deck prior to posting, but I'm working to get confirmation with Dr. Brown before I get that scheduled in concrete. So again, right now, tentatively, we're looking at December 19th at 2 o'clock Eastern, 1 o'clock Central. All right. Any other questions? Or anything, Carol, Emily, team, that I may have overlooked or forgotten to say? Anybody?
I just
Nothing.
thought I'd mention that the AQO Hot Topics webinars are on the STS Learning Center, and those can be, for our attendees, those are now available for viewing. And there's a link on the virtual platform right now in the left-hand side. It says AQO Hot Topics webinars, and if you click there, it'll take you to that website. And we'll probably also put we'll send information out to the attendees here soon too in an email, but they're available.
Yeah, also, just from the STS website for, again, like as we had mentioned earlier, the STS Learning Center, AQO virtual platform information will be moved over to the STS Learning Center. If you're not familiar with where that is, if you go on the STS website from our homepage here, click on education, and in the drop down, is it online learning, Emily? Is that where it's at?
Give it a go.
Give it a go. Let's see.
I'm not sure. Yeah,
Yes,
STS Learning Center right there.
Visit the STS Learning Center for all of your educational needs. So click the STS Learning Center link here, and then
They're on there now.
so access online learning for the full list of activities here. So here it is, advances in quality and outcomes. So you could just click here for
And
all
then
of our AQO.
yeah, and then the people who attended AQO, you're already enrolled. So it says enroll here right now, but that's just because Leanne is not
Right.
enrolled. But you'll just log in with the same credentials that you use when you log into our website to get the data collection forms, or the same login that you used when you registered for the meeting. Is how you'll log in.
Excellent. Thank you, Emily. Oh, the ebook. I love the STS ebook. All right. I am not seeing any other questions from anyone. Let's see. I don't see anything. Nancy, Banu, anything from our STS help desk side of things? All's been help desk land?
No, no questions from me, but if there are any questions regarding help desk, I'm happy to take them.
And of course, our contact information, here's my info here, help desk support. So if you have questions, harvest questions, when the report comes out next week and you're looking at your information, you're looking at the STS, at the analysis overview, you have questions for some reason, what's in the overview, what you see in your platform, in your database, what's being reported out. You have questions, you don't know why this number matches, you can't match this number in the report. Please email all of those questions to stsdb_helpdesk@sts.org.
And remember to send screenshot.
Screenshots, yes, screenshot, the question, the table you're looking at, the highlight, the number you're specifically questioned, the more information you can give the help desk, the better. So again, please don't email me directly. In the past, back in my DCRI days, I could answer those questions for you, as had access to everyone's reports. I do not have access to everyone's reports here at the STS in this role. So again, reach out to help desk at STSDB_helpdesk for all report related questions next week. There's questions that can answer, Banu and team will forward them on to me. And then they'll also forward any questions on to our analytics team if we need to get them involved. As Nancy had a question earlier regarding invoicing. Once invoices come out, you have questions, please reach out to stsdb@sts.org. They can handle all of those invoicing questions. If you are not sure who to reach out to, please just reach out to the help desk, stsdb_helpdesk@sts.org. Always just go to the STS help desk. if you are not sure who you need to reach out to. They should always be your first point of contact. Okay. Not seeing any additional questions come in, so I guess I'll give you guys back about 6 minutes of your afternoon. Thank you everyone for joining today. I hope today's webinar was helpful. If you have any questions, again, just let us know. We're here to help in any way. So with that, I hope you guys have a great rest of your afternoon, and we'll go ahead and end for today. Thanks everyone for hopping on and joining. Thanks all of my STS and colleagues.